As a young citizen of India, armed with technology, knowledge, and love for my nation, with a vision of transforming India into a developed nation, I'm joining Shobhit University. What about you?
Very good morning from Shobhit Institute of Engineering and Technology, Meerut, deemed to be university and its centers of excellence, Center for Informatics Development Solutions and Application, and Center for Industry 4.0 Technology Studies and Applications, in association with African Asian Rural Development Organization, ARDO, New Delhi. Greet all the participants from India and abroad. We organize this weekly international webinar series on open source digital technologies towards self-reliant India, Atmanirbhar Bharat. Today is 29th May 2021. On behalf of the Honorable Chancellor, His Excellency the Secretary General Ordo, Honorable Vice Chancellor, the faculty members of the university, and on my behalf, and as Professor Emeritus and the Chairman of the Centers of Excellence, Center for Agricultural Informatics and E-Governance Research Studies, Center for Agribusiness and Disaster Management Studies, Center for Informatics Development Solutions and Applications, and Center for Industry 4.0 Technology Studies and Applications. Let me welcome our guest speaker of today's webinar, Professor Dr. Sanghmitra Sheel Acharya. Good morning, madam. Is a professor at the Center of Social Medicine and Community Health, School of Social Sciences, Jawaharlal Nehru University, New Delhi. Madam, under this international webinar series, these two centers of excellence of the university have organized so far 29 lectures on the topic Open Technologies to Provision Simple and Economical IT Infrastructure, a roadmap for students using free and open source software and reaching goals of Atmanirbhar Bharat. Open source software and industrial IoT for SMEs. Free and open source software adoption and business models. Open data platform for smart digital government. Technology imperatives. Make in India for self-reliance. Edge artificial intelligence. Data governance for self-reliant India. Digital India transforming governance and society. India's email service. Citizen and indiamail.com in 22 constitutionally recognized languages. Ecosystem architecture for digital transformation. Education system, cyber critical infrastructure. Seizing opportunities in open innovation and value creation network in the digital world for self-reliant economy. Ensuring food safety and compliance through technology. Digital India, urgent need for semiconductor manufacturing in India. Technology investment in agriculture value chain, role of foreign direct investments, entrepreneurship and skill development, artificial intelligence design pathways, the rise of platform economy, revisiting value chain governance, the era of automation, industrial robotics, and Industry 4.0 Indo-German perspective of technology transfer, skill gap analysis and opportunities. Role of artificial intelligence in healthcare, current developments in diagnosis and vaccine research, digital agri-tech and agri-startup perspective. Health informatics network value chain, e-health system and beyond, leveraging emerging technologies for ensuring transparent and traceable agri and food supply chain, unleashing the power of citizen development for enterprise software development, e-governance models towards sustained quality service to citizens backed up by technology. Indian MSMEs to adopt Industry 4.0 technology capabilities, urgent need for mentorship and accelerator program. Building public digital platform using microservices and APIs. Health informatics network value chain, early childhood development and learning. Health informatics network value chain, clinical artificial intelligence, interface between machine learning and health informatics. Today is the 30th edition of this very important webinar series. We'll have the talk by our guest speaker, Professor Sanghmitra Sheel, Acharya, on the topic Health Informatics Network Value Chain, Importance of Social Medicine and Community Health in the Times of Health Emergency. Please note the keywords of the title of the talk: Health Informatics Network Value Chain, Social Medicine, Community Health, and Health Emergency. To recall, on 23rd January 2021, Mr. Vivek Verma is an advisor of an artificial intelligence startup based at New Jersey, USA, talked on role of artificial intelligence in healthcare, current developments in diagnosis and vaccine research. On 6th February, this webinar had the talk by an NRI entrepreneur, Mr. Nilesh Kennedy, whose organization builds up a customizable e-health system technologies for the world on the topic Health Informatics Network Value Chain, e-health systems and beyond. On 20th March 2021, Dr. Nadadur Janardhanan, IAS retired and former advisor to United Nations, talked on Health Informatics Network Value Chain, early childhood development and learning. Before this talk on 5th December 2020, Dr. Jawaharlal Binanchi Arachi, former principal advisor to the Director General UNIDO, Vienna, Austria, addressed the webinar series on the topic Seizing Opportunities in Open Innovation and Value Creation Network in the Digital World for Self-Reliant Economy. Health informatics value chain has subcomponents such as public health systems, plant health systems, animal health systems, fish health systems, soil health systems, water quality systems, and air quality systems. According to the research by Dr. Alex Carroll, is a Nobel laureate in 1912, he published the book Man the Unknown. In this book, he talks about that how soil cells are, impacting the metabolism of the cells of human, plant, and animal. Digital technologies in healthcare are as follows: database technology, big data technology, and decision support tools, web technology, IoT, web of things, sensor technology, GIS technology, artificial intelligence, language computing, remote sensing technology, 3D printing, blockchain technology, social media technology, cloud computing, TV white space technology, and mobile technology. We hear a lot of words such as e-health, digital health, health informatics network value chain, community health, and social medicine. Today in this webinar, you will have the talk by the eminent scientist and academician, Professor Sanghmitra Acharya. Let me inform the participants, the list of topics in the webinar series is growing, which are relevant to the present need. Atmanirbhar Bharat is the vision of the Prime Minister of India, Shri Narendra Modi, of making India self-reliant nations rested on 5 I's: intent, inclusion, investment, infrastructure, and innovation, based on 5 pillars: economy, quantum jump and not incremental; infrastructure, one that represents modern India; systems, 21st century technology driven; vibrant demography, source of energy for self-reliant India; and demand, whereby the strength of our demand and supply chain should be utilized to the full capacity. This was announced on 15th May 2020. Digital world, the rise of platform economy, application of big data, new algorithms, AI, blockchain technology, open API, and cloud computing is changing the nature of work and the structure of economy. Digital platform economy is emerging, and digital ecosystems are essential for digital transformation in the digital world. Digital health platform is a multidisciplinary domain involving many stakeholders, including clinicians, researchers, and scientists, with a wide range of expertise in healthcare, engineering, social sciences, public health, health economics, and data management. Three popular domains of digital health technologies include telemedicine, wearable technologies, and augmented and virtual reality. Computational simulations, modeling, and machine learning approaches can model health-related outcomes. Digital health platforms continue to emerge and evolve. One Health and Eco Health. Digital health means artificial intelligence and machine learning based on platforms that aggregate patient data. A digital healthcare ecosystem is an infrastructure that supports the shift from an organization-centric to a patient-centric model of delivering healthcare services using digital platform. National Digital Health Mission of India, One Nation, One Health, aim to streamline digital health ecosystems in India. Health informatics value chain has the components, as I mentioned earlier: human health, plant health, water health, fish health, animal health, soil health, air health. Indian healthcare system includes allopathic system of medicine and Indian system of medicine, Ayurveda, Siddha, Unani, and homeopathy. Central government is formulating an integrated health policy, one nation and one health system by 2030 that would integrate the modern and traditional system of medicine such as allopathy, homeopathy, and Ayurveda in medical practices, education, and research. Health informatics, as established, uses information technology to organize and analyze health records to improve healthcare outcomes. Health informatics is a rapidly evolving field and getting influenced by and impacting on many different knowledge domains such as nursing informatics, dental informatics, public health informatics, medical informatics, biomedical informatics, consumer health informatics, computational biology, telemedicine, electronic health records, data interchange through standard, etc. Digital transformation, building public digital platform using microservices and APIs. The fourth international revolution is the ongoing automation of traditional manufacturing and industrial practices using modern technology. The key technologies are A, B, C, D, E. A means artificial intelligence, analytics, operational research. B means blockchain. C means cloud communication, cloud, IoT, 5G communications. D means big data, and E means ecosystem. Industry 4.0 is today, and Industry 5.0 is tomorrow for healthcare industries and hospitals. Let us come back to today's topic. Let me explain some of the terminologies for the benefit of the participants who may not be from this, subject, for them to be ready to receive the address by our guest speaker today. Social medicine. The definition of social medicine, according to Merriam-Webster's dictionary, it is organized investigation of social, genetic, and environmental factors influencing human disease and disability and promotion of methods of prevention of disease and health measures protective of individual and community. Let me repeat, it is an organized investigation of social, genetic, and environmental factors influencing human disease and disability, and promotion of methods of prevention of disease and health measures protective of individual and community. The field of social medicine seeks to implement social care through understanding how social and economic conditions impact health, disease, and practice of medicine, fostering conditions in which this understanding can lead to a healthier society. The field of social medicine is most commonly addressed today by public health efforts to understand what are known as social determinants of health. Social medicine stand on the two pillars, medicine and sociology. Next terminology is community medicine. Community medicine is the branch of medicine concerned with the health of population. It strives to protect and promote the health and well-being of the community through a primary health care approach. The dimensions of public health includes social medicine, preventive medicine, community medicine, and community health. Community health is the branch of public health which focuses on people and their role as determinants of their own and other people's health, in contrast to environmental health, which focuses on physical environment and its impact on physical people's health. Public health has been defined as the science and art of preventing disease, prolonging life, and improving quality of life through organized efforts and informed choices of society, organizations, public and private, and communities and individuals. Health emergency. COVID-19 is a global public health emergency. World Health Organization declared that COVID-19 is a public health emergency of international concern. According to Lucas Jacob Trout and Arthur Kleinman in their article published in 2020, I quote from their article, COVID-19 requires social medicine response. Social medicine response. Because COVID-19 is a social disease. COVID-19 requires a social medicine response. Social medicine holds at its core a concept of health that unites the social, economic, and biology. Social medicine means delivering care according to need, which in the American situation suggests a corrective and preferential option for the poor, marginalized, and those without ready access to care. COVID-19 hands us a veritable checklist of serious problems to be solved. Diseases with social impact require a management approach based on social medicine, integrating health, social, and economic response. According to Luciano Popico and Saverio Bellisi and their article published in 2021, make mask wearing a social medicine against COVID-19, said Lieutenant Governor of Puducherry, Honorable Dr. Kiran Bedi, on 4th October 2020. COVID-19 shows the world needs physicians who can look beyond medical charts. COVID-19 has placed a spotlight on the field of social medicine. Social medicine shows its strength during COVID-19, but only when paired with the technology, according to the article by Michael Kaminsky. Technology used in Taiwan, single payer system, is likely the best reason the island was able to control COVID-19. The key component of Taiwan model is technology. Every enrollee has a smart card, and when the patient visits a clinic or a hospital, a medical professional places the patient's card into a reader. All but the most sensitive medical data is then available to the physician. This reduces overcharging, fraud, and doctor shopping and duplicate medical services. Smart cards and centralized databases using cloud computing combined into an integrated electronic framework that allowed the government to track patients with the symptoms, do immediate contact tracing, and set up effective quarantine regimes. Early in 2020, Taiwan authorities widely scanned the databases for individuals who had reported flu-like symptoms do immediate contact tracing and set up effective quarantine regimes. The patients who were tested for COVID-19 and positive cases were quickly isolated and contacts traced. Taiwan's National Health Insurance is reportedly now exploring ways to increase the use of online doctor consultation. The future is online. Databases, smart cards, and online doctors. The longer a nation waits to embrace the future, whether through private or public systems, less prepared it will be for the next inevitable pandemic. COVID-19 has given the world a glimpses of the future. With this background, let us now turn to the address by Professor Dr. Sanghmitra Sheel Acharya on the topic Health Informatics Network Value Chain, Importance of Social Medicine and Community Health in the Times of Health Emergency. In this talk, we'll come to know the importance of social medicine and community health in the times of health emergency, and also to understand, according to her synopsis, the positives and negatives of health informatics from the perspective of social medicine and community health. This topic will motivate and galvanize the participants watching over telecast through facebook.com/Sobit University India or youtube.com/Sobit University India for motivating them to establish health tech startups in healthcare to strengthen health informatics network value chain in the country, facilitating no lockdown due to pandemic, if any, in future. Social medicine and community health startups, etc., etc. Let me introduce our guest speaker to the participants of this webinar. Professor Dr. Sanghmitra Sheel Acharya is a professor at the Center of Social Medicine and Community Health, School of Social Sciences, Jawaharlal University, New Delhi, and former director, Indian Institute of Dalit Studies, New Delhi. And he is also the chairperson of the Center of Social Medicine and Community Health. Professor Sanghmitra Sheel Acharya was a visiting Chinese Academy of Social Sciences Fellow, China during 2012, adjunct faculty in the Department of Sociology, Ball State University, USA, visiting faculty and ASF Fellow at University of the Philippines Population Institute, Manila, visiting fellow at East West Center, Honolulu, Hawaii, and UNFPA Fellow at University of Botswana. Professor Sanghmitra Sheel Acharya has been awarded fellowships and grants by UNFPA, Asian Scholarship Foundation, United States Educational Foundation in India, ICSSR, CAS, and Sastri Indo-Canadian Institute. Professor Sanghmitra Sheel Acharya has chaired sessions, delivered keynote addresses in conferences, seminars, and policy meetings in India and abroad. She has authored 3 books and about 50 articles on health and discrimination. Her recent work includes co-edited books titled Marginalization in Globalizing Delhi, Issues of Land, Labor, and Health Safety and Well-being of Workers in the Informal Sector in India, Lessons for Emerging Economics, both published by Springer. Her current work titled Sustainability in Health is ready for publications. Madam Professor Dr. Sanghmitra, we welcome you to the international webinar series on open source digital technologies for self-reliant India Atmanirbhar Bharat to talk on health informatics network value chain, importance of social medicine and community health in the times of health emergency. Over to Professor Sanghmitra.
Thank you. Thank you so much, Professor Moni, for this very elaborate introduction to the whole initiative of this conversation that the university has taken over. And I really put my gratitude on record for the university and its associate like ARDO and co-learning and other centers within the university who have decided to take on board what is needed today when it comes to Atmanirbhar Bharat. I would like to put into perspective from, like you've already said very clearly, from the vantage point of social medicine and community health, and how do we see this becoming relevant in these difficult times that we are today. I will try to, I understand that this is particularly for the benefit of the students who are interested in this area. So I've tried to orient myself in a way which I am in a position to communicate to the students. I would use the slides and I'll try to share some of them as I connect with the. Okay, so is it visible? Prof. Moni, is my... Okay.
Yes, ma'am, it is visible.
Yeah, I just wanted to check whether it's visible or not. Fine. So, like you've already stated for the listeners, that my concentration today will be largely connecting how health informatics, the network value chain, and social medicine and community health become relevant in these times, which is COVID-19. We all know that this is something which is unprecedented. This is something which perhaps if we go into the history of about 500 years backwards, we see that there are about 15 big and small pandemics which have affected the world at different time points. Something which is very interesting to note that by and large, over a span of 80 to 100 years, there's been one major pandemic or the other which has affected humanity in a very, very difficult ways. And the last one, which we all been trying to compare COVID-19 with, is the Spanish flu. I would like to start with kind of suggesting how does health informatics therefore becomes important. And you very rightly initiated by suggesting the listeners, the young listeners, that this is a component which puts together what is it that we need to do for ensuring health to the populations. And for that, the network that is created, the line of action that is created begins right from what is the information, how do we process that information, where do we store that information, where do we collect this information from, and what are the norms that we follow in collecting this information, what are the ethical concerns in collecting this information and processing in this information in such a way that it leads us towards certain kind of problems which we see in terms of health, in terms of health of the individuals, which could lead to become the population groups. And that's perhaps where the health informatics connects both with the medical sciences as well as let's say demographic sciences and health sciences. When we talk of the collective, the direct link it's with the medical sciences, with the health sciences and the demographic sciences. And the moment we are talking in terms of individual cases, we know we are on the clinical aspect of this health informatics. So we very rightly, you've kind of opened it up in terms of suggesting that the core of health informatics remains promotion of health among people who are part of families, who are part of communities and the larger world. Therefore, how do technologies, how do information and communication realms, the systems which enfold these, they become important in terms of enabling this positive systems of healthcare provisioning, healthcare service provisioning. And therefore, the markers for it become very relevant for us. Where is the data? What is the nature of the data? How do we collect this data? What do we do with this data? How do we retrieve this data in such a way that we can process it for problem solving of various kinds which pertain to health of the populations. And for all of this, we need certain kinds of management realms. We need certain kind of systems which allow us to retrieve this information, process this information, and use this information for, like it is the norm, the promotion of health. So we actually see that there are three basic domains in which we can put health informatics. The very regime of healthcare, how is healthcare provisioning done? What are the systems through which healthcare provisioning can be done in order to prevent infections, in order to prevent diseases? If they occur, how do we treat them? And what are the realms of, therefore, the management of illness too, in case of the occurrence of the disease happens? So from prevention to promotion of health, through various kinds of services which could be offered, direct clinical services, indirect services which pertain to health, which include counseling and psychological health services as well. Then we have the second realm, which we could very well talk in terms of the digital constituent, wherein we use the technologies which are computer-based, wherein the logic of artificial intelligence also comes in. Here is the realm which I'm sure has changed lives for many of us in many ways. We can imagine the times which were 20, 30, 40 years ago, when computers were still rare and not so easily available. Now I'm sure they've become part of lives for almost all of us. Therefore, the computers become very, very important for the information that could be collated in a particular way, and the use of that collated information, the techniques which could be used through these mechanisms which computer offers us, different packages of data processing which we can use through the computerized systems, which allow us a lot of saving in terms of time, a lot of saving in terms of communication of information across various, if I may use the word, stakeholders. The third realm, which becomes very important constituent of health informatics, is of course the very information science. And the usage of the term science very, very conscious, because the moment we start collecting data, we need to do something with that data. And the first step perhaps that is that we classify that data in such a way that it adds meaning to what we've collected. If we have collected data on people who have been vaccinated by different vaccines which are available to us at the moment, a good idea to make meaning out of this information is to be able to classify how many people have got vaccinated, how many men versus women, how many before, over 18 years, how many between a certain age group, from which vaccine has been given. So the second step, very important to give meaning to the data which is collected, the empirical evidence which is collected, is classification. And then trying to interpret this classification by giving certain meanings to it, interpreting that classification at some level, which will require the nature of how do we store this information? Where do we store this information? What are the ethics which are related in terms of, like I said earlier, both in terms of collecting this data as well as storing this data? Who will have access to this data? Why that XYZ will have the access to that data? And who can retrieve that data? So given the norms of ethics, there are certain parameters which are to be followed when the data storage is happening, data sharing is happening, and collation of data, processing of that data for various purposes is happening, because that's how it allows us to use the information to expand the knowledge, to use that knowledge in terms of creating interaction between people across different kinds of people, from those who would be making use of the data for various purposes. It could be individuals, it could be organizations, it could be different institutions wherein this data could be made use of. The third aspect then becomes very important for us in terms of, in a way, kind of summing it up. For the understanding of health informatics, there are certain records which need to be maintained in such a way that they are more readily available than perhaps the erstwhile record keeping of a very physical form, wherein you have to stack them in huge record rooms and tracing them with the catalogs, etc., etc. Of course, cataloging is happening here also, but of a different kind, which is retrievable at a much faster rate. And I think that is what all is when we talk about health management information system, which most public, in fact, both healthcare system, tertiary level healthcare system facilities have incorporated, and using that data vis-a-vis the management of that information that has been collected, who is going to use, why, that who is going to use for what purpose and when. And all of this has to be in certain fold of decision making of these who and why and what of the data dissemination, data use. For all of this, one realm which Prof. Moni has already spoken about in terms of telemedicine and telehealth, therefore, particularly in these times when we are staying home, when that's the norm of the day, when there is the norm for the call to address or rather restrict the spread of the pandemic, when we are expected to stay home, telemedicine becomes one important realm to take on board the communication that could happen between the care receiver and caregiver. Of course, following certain standard procedures, not only in terms of provisioning of counseling, provisioning of service, which is required, but also in terms of like the very parameters of the data which is being therefore generated. How will this information be taken on board in terms of the benefits or not so good benefits is also an important realm which becomes part of health informatics. And that's the realm I've been trying to suggest in terms of the ethics which are involved in this collation of data, in this distribution of data, sharing of data, vis-a-vis the security and the ethics which are important, because I'm sure we are all familiar with research, and we know very well that any data that we are collecting has to be confidential. We cannot be sharing, we should not be ethically sharing the data. Therefore, these realms which are important when we follow certain regimes, when we evolve certain regimes of health informatics. And that perhaps takes me to a very important context that we've been talking about in terms of one nation, etc. So something which perhaps emanates from a fairly old or rather ancient understanding of the idea of health itself, way back to Hippocrates, and we're all familiar with the notions which come across in terms of health vis-a-vis what Hippocrates evolved during as early as 460 to 370 before Christ. And in his text, Airs, Waters, and Places, this is considered to be the genesis of what today we recognize as public health, because here is the intersection of nature and of human being and everything else that comes in between the nature and the human being. How does the interaction between nature and human beings happens becomes fairly evident when we look at this treatise, which was created that early in the times. And we all know he's supposed to be the father of the ancient medicine. Similarly, if we recall what Virchow said in 1800s, late during his research, when he coined the term zoonosis, he brought in the realm of the relevance of animals and how animals and human interactions become important in this whole gamut that we can see in terms of man-nature environment connect, man-nature environment or man-environment connect vis-a-vis the realms of all entities that make the total, which is environment, all the constituents which comprise environment. And therefore, I think it becomes very important to understand this phrase, one medicine, which was developed and promoted by Schwab's. I'm sure many of us are familiar with his work and his ideas, wherein he very vociferously talks about this interconnect between human and animals. We take agriculture, for example. The whole livelihood is dependent on this connect between humans and animals. Think of diseases. A good number of diseases have the connect or the genesis which is born in the insects or the animals. So the idea of putting all of this together in terms of understanding the unison of these various factors which become relevant in making us get a sense of why it has to be seen in the kind of unisons which Prof. Moni has also earlier spoken about. He's brought in the realms of soil health, for example. And therefore, to just reiterate the whole idea of this one health that we are talking about today in context of what we recognize as public health is nothing different from the way, if we could say, that the very evolution of the terminology, how when we say preventive health, for example, in earlier times, in early, let's say, when we start talking about the works of Virchow, for example, preventive medicine gives us that connotation that there are illnesses which happen to human beings and also to the animals, and which need to be prevented for the congenital, for the way in which a good connect between the man and the environment, with animals, insects, everything else coming in between, can happen, can continue. The confluence between these elements that create nature, for example. And therefore, the second realm which became important was to see in which conditions are these illnesses occurring, are these diseases occurring, to whom are these diseases occurring, for example. So the socio-economic realms of populations, which could be relevant, which became important in terms of understanding the patterns of occurrence of diseases. And that's where perhaps also why today when we talk of social determinants of health, it emanates somewhere from this whole logic of taking note of, taking cognizance of the social environment in which human populations could be located. And therefore, where do we get this realms of how do we cure, if I can use that word, how do we provide care for the illnesses that are evident, which are visible, which are happening among the people. There are possibilities of evolving the local knowledge also. And one of the constituents of local knowledge is within the realms of how indigenous medicinal systems have evolved over space and over time in terms of taking care of the health of the people. And therefore, the constituents today, when put together, have gained this recognition of a common phrase or a common name that we can probably suggest as public health. People who are under certain kind of systems of ecological systems, certain systems which provide them work, occupation, which provide them housing, which provide them natural resources. The layers of these ecosystems in which human populations are located need to be taken care of. And that's why the very scope of public health as WHO defines it very necessarily becomes relevant in terms of how do we measure these alterations that happen in health vis-a-vis disease, and therefore how can they be promoted? What are the realms in which we can promote health? What are the realms through which these promotions become important? Because longevity, for example, is one of the aspects for which a lot of populations strive to work towards. And we all know that today, in the current context, the Sustainable Development Goals, the third goal of Sustainable Development Goals is directly talking about attaining health for all, and that was, of course, the call of Alma Mater Declaration way back in late 1970s. So what we can therefore connect with in terms of the public health is how do we ensure that the total population, the entire population, irrespective of differential access to resources, can be made healthy. And therefore, it's the totality of the system which becomes relevant in terms of addressing the health needs of the individuals by eradicating various diseases which affect individuals in various ways, who form the part of this larger constituent, which are human populations. And this is precisely, perhaps it becomes therefore important to connect with the current scenario, wherein we've seen that when we think of the pandemic today, we see that it has impacted across the globe, irrespective of the region, irrespective of the gender, irrespective of the communities, if I could use this word. It's only when we analyze this data of infection having happened, we realize that there are certain patterns which we can evolve, and we'll get there in a short while. And therefore, before getting there, I'll just quickly want to get to the applications which connect very directly with the pandemic scenario that we are in today. So, given the fold of public health, therefore, we ought to be assessing what are the current services available for the pandemic, for example. If we recall, last year, fairly much in the month of February itself, the government had taken on board the cognizance which the WHO had made of the advent of this public health emergency towards the end of January. The government had already taken note of it and stopped the export of certain gadgets which were required, the PPE gadgets which were required for ensuring what the WHO had said, that each country is supposed to have adequate stocks of it. So that cognizance made the government swiftly work for it and put a stop to whatever was being exported at that time. Of course, gradually we realized that our needs were far more, and we had to, in fact, import from other countries gradually. But the idea that the assessing of the situation has to happen, and it happens in a certain form. And then what are the appropriate interventions that we could do? And one of the interventions that we see comes in the form of the lockdown, comes in the form of stay home appeal to the people, putting on the mask, washing the hands, etc., etc. Of course, there are, for any action which is done, there are certain negatives that we can figure out which are there, and we might want to take them on board. For example, staying home perhaps wasn't possible for everybody, particularly those of us who are in the informal sector. We needed to go out for work. Since we did not go, we lost work, and we probably had to also starve, and more of such things happened too. And the much of the documentation which has happened on it. But given the call, perhaps of the time, then it was important to restrict movements of the people and nature, and therefore perhaps the state had to do that, even when the considerations were the priority was to take care of the spread. And as the spread recedes, there is opening up happening because livelihoods become equally important, and therefore that's something which becomes important for us to take note of at this point. The other aspect, which is probably very important for us to note down, how do we think in terms of the effect of the resources and the cost effectiveness of those resources? Two things which come to my mind immediately is the preparedness within the healthcare system. For which if we go back to last April 2020, we see that the system got galvanized and there were a good number of hospitals which were marked for COVID treatment. There were a good number of beds which were placed in these hospitals. Manpower was also directed towards it. So much so that there were evidences that other services were getting affected. Nevertheless, this was an emergency. The call was to address this. Therefore, this is what was happening. But the second part of the story also suggests that how many of us were in a position to access these services. And we see this dichotomy happening even outside the pandemic domain when we look at the private sector provisioning of health services versus public sector provisioning of the health services. The differences in terms of the out-of-pocket expenditure which is incurred, we do understand that the private sector did have a very important role to play in terms of extending their services, but to a certain segment of population which was able to afford that kind of services. Something very noteworthy at this point through the pandemic is that the second wave, as we've seen it happen through the last 2.5 months, has probably for the first time given us feelers that even if the economic propensities existed, the lack of the system, lack of the efficiency within the system in terms of ensuring availability of the healthcare personnel, availability of the procured services, the medicinal substances, etc., was not conducive to the economic propensity. Meaning to say that even if you were rich enough, you were not in a position to access the oxygen, you were not in a position to access the hospital bed, irrespective of the kind of money you could be rolling in. So something which makes us think, therefore, that in these times when the health management information systems have been put in place fairly many years ago, Digital India is the norm of the day. What was it that was going amiss in terms of enabling the use of real-time data information, and making all that happen, which was given on the websites, availability of the hospital beds, for example, to get executed immediately? What was it that was going amiss when we were not getting information of the availability of the oxygen cylinders, for example? Or what was happening to the change of, or what I read from the ministry's report, the liquid oxygen was to be generated from the industrial oxygen, and my understanding from that report is that it's just about half of that total production is being used, at least till April. So where did the mechanisms, what was happening to the informatics, the systems which are inbuilt in the informatics for ensuring or informing the common users, the systems, the organizations which were there. Therefore, the point is that despite that there is a very robust kind of a system which has been put in place in this age, which talks about artificial intelligence, which talks about digitalization is the is what is going to stay. we need to strengthen this in certain ways so that what is in place can actually be made use of also. And therefore, to my mind, the planning of the health services will become far more robust if these systems for holding, collating, sharing information becomes more active. And this will also therefore benefit the whole spectrum from the individual user to the larger systems which could be disseminating information. We've seen how small units, small groups, individuals, larger groups, NGOs, CBOs have galvanized to be able to do their small bit that they can in terms of joining hands with the nation in combating this pandemic. Therefore, this perhaps could be a reiteration what I've just said. How do we make this robust systematic application of this robust in system which is already in place, putting all of this together in such a way that on the one hand we get this data in its real form, so that some processing of this data can lead to certain research, which would in turn lead to certain insights to lead us to be able to plan what is to be done next. All the more because it's almost a year since we saw the first rage of the pandemic, and we're still having something else to cope up with in certain terms. But some of the states, some parts of the country have managed to take note of the situation and have responded in a particular way, which has been very meaningful. Bombay, for example, in the last few months, for example, has been able to capture how it can restrict the spread. Unlike last year when Dharavi became one of the hotspots, this wave, Dharavi seemingly has not had even a single case. That's still about March. I stand corrected for the later time point. Similarly, Kerala, for example, the creation of the very chain of identifying, then treating, and then contacting and treating the individual, testing, contacting and treating. I think that perhaps becomes one of the very important, I would say, became the model for many of the states to emulate because of its success story, in the sense that it could capture the spread in a very systematic way within early months. And then the spread, not that the spread stopped, but the spread was in within the folds of the governance and the leads of the governance, wherein they could track them down. They evolved something, these units which are now recognized as war rooms, wherein which is actually using that real-time data in terms of disseminating the care, disseminating the personnel, disseminating what are the steps for it. In this realm, something which also becomes very important, particularly from the point of view of social medicine and community health, is sharing of the information. And I would want to say very categorically, right from the beginning, the information on the very virus, to the infection, to the vaccination, and to the non-availability of vaccination, perhaps has been such that it's very well done, very elaborately done in the guidelines. But what happens to the common man for whom the guidelines may not be accessible? One, two, if accessible, they may not be easily comprehensible. So the role of this public health informatics very importantly has to engage with pulling out certain modules which could be much more easily comprehended by common man in terms of understanding what happens if, for example, the gap between two vaccination points increases or decreases than the stipulated date type period. What happens if I have not been able to contract not been able to get my second dose, for example? What happens if my breathing trouble aggravates, for instance? All of this for sure is very well documented in those guidelines, in those brochures from various ministries and agencies. But something which needs to be translated to the common man in a way which is more comprehensive, more easily comprehensible, is perhaps more important, because that's where perhaps it will lead us towards creating that kind of information which is genuine and I can believe on it as a common person. And then to follow, I mean, all that we're talking about, vaccine hesitancy perhaps has a lead right in here. The information which needs to be disseminated in the right way for why we need to get it. It's like I said, how do we translate the guidelines for the comprehension of the common man becomes very, very relevant. And I would want to use this health belief model perhaps to to connect with the condition that we are in today. Whole lot of information that we can make use of. Who are the ones who are getting affected by the spread of this disease, infection or disease, or whatever you would want to label it as? Who are these people? The class, the gender, age, for example. What is their psychological characteristics? And this becomes very important because we've all seen in the last year's spread. First thing which was very evident both by the police records and CRB records and by the National Commission on Women, that domestic violence has risen tremendously, almost 100% during the first phase of the lockdown. Now, that is one. The other is the loss of wages, loss of work, loss of your loved one, and the very idea of touch deficiency. I would label it as touch deficiency because you can't talk to people, you can't go close to people. All of this is creating certain kind of psychological stresses in the people. All this while we've been trained in our respective socio-cultural milieu that we must visit people when they are unwell or somebody passes away. That's more important than visiting people when they have birthdays and marriages, etc., etc. Meaning to say that it's always better to share grief with a person than share a happiness. From the perspective of somebody who's bereaved. Here is the time that you can't even do that. I'm sure the second wave has not left a single one of us who doesn't know a person who's been lost to COVID. So in that kind of touch deficiency, the kind of anxiety, the kind of stress that is happening, there are children who have lost their parents, there are people who have lost their loved ones. What happens to them? So in this, do we see certain kind of susceptibility to certain kinds of people, the degree of susceptibility? How can they be motivated to overcome those conditions? What will be the benefits that we can attribute for these kind of supports that can be generated from the point of view of the support and to the person who would be perceiving those benefits? For example, what are therefore the line of action that could be created? One of the examples that I was saying is making more comprehensible, kind of more easily comprehensible kind of text which is there in the guideline. So going from here, I would want to use something which comes out as early as 2019 paper, which is using a mobile app for epidemic surveillance and how it can be used for the response. And we've seen today in the times of this pandemic also, a lot of social media becomes active in terms of sharing information, good, bad, or ugly. We can all debate about, and I'm sure there are all kinds of information which are there. But this app, for example, this gadget, for example, does allow us to connect with different stakeholders in a much faster way, and both communicate the right and the wrong. What is the right and what is the wrong? We all can probably make our discretions to judge, or appropriate and inappropriate. Perhaps that may be a better form of it. So that can perhaps be something wherein we have, and we already have evidences in a good number of research which is using this gadget for reproductive and child health, for example, concentrating on what is happening to the children below certain ages in terms of their intake of vitamin recipients, etc. So something which is already in the fold, which is already laid out, needs to be tracked out from there and put in place for this particular kind of an emergency situation that we are talking about. And war rooms perhaps are one very live example of this kind of use of the gadget and the data system. Therefore, I would want to perhaps get down to relating this with the timeline of how do we see all this pandemic becoming this kind of an havoc that it has become. We all know that it's way back in November 2019 that the first cluster pneumonia was reported, and it was labeled as something which is of an unknown etiology, and we know the city was Wuhan. And by 31st of December and 3rd of January, between this time point, we had 44 cases which were reported to the WHO office of China. What was more important is that the causal agent was still not identified. First time, it was also confirmed that human-to-human transmission is what was causing it back in 20th of January, more than a year ago now. And 1 month, roughly less than a month down the line, we had nearly more than 175 cases which were already outside China. So the outbreak had spread out beyond what till then perhaps much of the world was thinking as being restricting itself there. So after this, we do have WHO cautioning us to stock up our piles, declaring it as a pandemic, and very categorically says that testing, tracing, and treatment is the way to combat it. And Kerala was one of the states which actually took note of it fairly quickly and started working through that in that form. And by then, the pandemic had already spread in fairly many countries, and the WHO chief had to very categorically appeal to the global community that we have to kind of take care of this pandemic, overcoming all our internal matters and differences that we might be having. So when we look at, in this backdrop, when we see what was happening in India, the first case was reported, officially reported on 30th of January. A student was coming back from a city studying in China. The first new case, that's the case which was added on 3rd of February. Another case was added. A year later, on the same time point, we have about 11,000 cases being occurring on a single day. So over a span of year, this is the quantum increase in the spread, if we can just take this as an indicator. The first death was marked on 9th of April. There were 2 deaths which were reported due to COVID. By 1st of May in last year, we had 35,000 confirmed cases. To that, if we relate with the year 2021, we can see the increase which has happened. And therefore, the point here is to make us understand the phenomenal spread that the disease has had in the country that is ours. Also, similarly, we see in terms of the new cases, just about even less than 3,000 on 3rd of May. go to almost 300,000 in 2021. And what is also important perhaps to take note of that this springing of numbers, if you look at the daily increase, could be changing also slightly, but 7-day average has very neatly kind of progressed since the last year. Number of deaths also show us a tremendous increase. Recovery again has been tremendously more between the 2 time points. So by telling us, making this comparison, I simply want to perhaps bring out what has happened as a good sign and what has probably happened as not such a good sign. If you look at the testing, we get a sense of the increased number of testing also, but given the size that we are in, this increase perhaps still needs to be taken forward tremendously, from 3.5 in last year's to 21, less than 1/5, a little over 1/5 of the total, really makes it a little difficult for us. Similarly, if you look at vaccination, we do have numerous, we've kind of made records of sorts. I understand 9 crores or 16 crores in 90 days. That's kind of record, whole of twice the size of Brazil, I'm sure we've vaccinated. But the point, therefore, what I'm trying to say is, given all of this, we understand the gigantic task that we have ahead of us. It is important to take note of, therefore, to put in place what exactly is required in over here. And that's where perhaps what we generally understand as value chain network becomes very relevant. One entity, how does it improvise to lead towards another entity, and further becomes extremely relevant. And we're seeing it in terms of the connects between how the infection gets recognized, what happens to it, how does that translate in terms of care provisioning, what happens to the identification of the hotspots, how do they get the mechanisms to take note of subsiding the spread within the hotspots, and so on. So when it comes to vaccines and vaccination, we know that the 3 realms, the 3 of them which I think are important in our case, Sputnik also now becomes relevant. We see that Pfizer BioNTech, it has to be 6, which is now increased, and it has about 70 to 80% efficacy. Moderna again, 94% efficacy, and Johnson & Johnson, which is a one-time shot, has is comparatively lesser efficacy. Now, in this backdrop, we have we very well know what is the population pyramid, for example, for us. So the first thing perhaps needs to be put in place, or has already been put in place, but not kind of made in the domains which are accessible. What are these age groups, and therefore how do we require these vaccinations, for instance? That perhaps was the reason why the phasing vaccination was to be done in terms of the phases of different age groups. But that phasing is important to have been conducive with the availability of the doses also. So that's where perhaps something where the network of the value chain was required to be built in, perhaps got a disjunct or delinked in some way, wherein the required quantities could not be conducive to what was being procured. Therefore, I think what is being suggested is that at this rate of vaccination, which is just about 3% at the moment, we will need 3 years for sure to completely vaccinate the population. Although we have positive insights from the ministries and the ministers of information and broadcasting, who is hopeful that we will be able to vaccinate the total population by the end of this year. But if you look at the situation as it has rolled out from December 2020, the case fatality rate, the cumulative case fatality rate for India has been lesser than the global case fatality rate. And that's been there right from the beginning. But what is important to note here is that despite the fact that it has been lower than the global fatality rate, what becomes important is after December, we see that there is a kind of shift which is happening towards the age group. We have 60% of those who are infected were below 45 years of age, and 12% of the deaths which has happened to them. And there were more men who were infected, and even the deaths among the men were higher, 70% as compared to as against women, for example. The age group 18 to 44% was about infected, 52% of the infection was among that age group. And similarly, if you look at the deaths, we see that, which I've just said, 55% of the deaths were among the higher ages. And as we go to the younger ages, it becomes very important to take note of the fact that about 1% of deaths occurred between those who were below 18 years of age also. So a neat trend becomes visible that the younger ages were starting to get affected between when we take note of the situation in December 2020. Very, very clearly, the data which was shared by the task force on, I think, 29th of April, it very clearly shows how the difference between the infection in these age groups. We clearly see that from 19% to 20%, from 8.5 to 8.07, a very, very marginal decline. And here is another increase from nearly 3 to 4%. This is the pointer here is that with this kind of trends which are becoming visible, and we very well know what the socio-demographic profile of the country is, what the age pyramid is of the country, we ought to be preparing ourselves for these 30 million children who have got affected. And as per the records of certain crowdsourced data, there are 10,000 plus who have lost their parents. Similar numbers, or even more in millions, and it cuts across different sources, have lost work and their social ties in terms of loss of somebody who they cared for, their psychological stresses which are happening. So these are perhaps the new challenges which we need to inbuild in the systems that we are referring to in terms of health informatics. Therefore, very clearly it becomes evident through the same data set. If we analyze it, this is already on the public domain, we see that the age group 13 to 50 seemingly is more affected in the second wave as compared to the first wave. So now, if this is the scenario, and this is where we find ourselves, the positive side is that we have started to see a declining trends in the number of infections as well as number of deaths after, let's say, the second week of May, which is a fairly positive sign, and the experts are hopeful that we will be able to rein the third surge, which has been kind of proposed, which has been predicted. So what is therefore important for us to take note of and talk about and think about is the health budgetary allocations. We have been hearing this, reading this, and discussing this, that we have the social sector has very, very small budgetary allocation. Education is yet another one. We still have about less than 2% of the GDP, which is stored for health, and this is by the National Health Profile of 2019. The out-of-pocket expenditure is something between 50 to 70%. Rural is more than the urban. Urban is about 54 or 53% or so. So this is an important time for us as state to wake up and take note of the increase in the health budget, and of course, and perhaps for education also, because in many ways both these sectors go hand in hand. The other realm is the availability of the human resource for health. We've all seen that when we talk about the human resource for health, there are certain there is a very tiered structure which is available in terms of what the health system is for India. We have sub-centers, we have the primary health center, we have the community health center. We already have a very strong network of the health sub-centers, which can be made use, particularly to address the need of the day-to-day. But what is important to consider is this: how will these become functional to address the needs of the COVID? All this while the concentration has been on the urban areas, and as the spread is happening in the rural areas, I think it becomes irrelevant for us to take cognizance of these centers which are available for us already in the structure to train the personnel. Training is already happening, and I was listening to the news the other day. There are already lakhs of grassroots level workers which have been trained as vaccinators. So ensuring that these individuals can be put in place to man these centers. One of the suggestions which has often been, which can be considered, is that the positions which have remained vacant in the health system and at all tiers, can those positions be filled by way of using those applicants, the applicants who have applied for various positions? Can they be offered those positions, perhaps conditionally, that they man a particular center as a COVID resource person, as COVID part of the COVID response to the need of the day, and then they can be absorbed in the system. That perhaps takes care of a lot of rigmarole of holding the interviews, etc., etc. Not that they are not important, but this is the emergency. This is the time when we are already under the National Disaster Management Act. This can be made use, and the trigger can be in terms of ensuring that the facilities which are structured, which are created, or which are lying unused, idle, can be made use of for these purposes. What is happening today, what I gather from the news yesterday, that the malls and the cinema halls are being used as drive-in vaccination centers. These very places could have been used for isolation centers, also could have been used for oxygen camps, also in the times when there were no spaces available, no stacks available. Institutions, universities, especially those institutions which already have a medical unit, care center, health center within their premises, could have used their facilities in offering the services to the affected community of the institution, and also those outside the community, because this is the call which is where we need to kind of see beyond the self that is ours. And that's perhaps the dilemma of this pandemic, which has put us all together in the frame of me and myself alone, because you're not supposed to be meeting people, you're not supposed to be touching people, you're not supposed to be going near anybody who is infected or suspected to be infected also. So some of these aspects perhaps need to be taken care of and built in over there. The availability of the stocks of various kinds, the medicines, the oxygen, the trucks which need to carry oxygen, the hospital beds, medicines. I mean, this is something which we've been hearing from perhaps a fairly long time, that there are duplicate medicines which can be available. There are medicines which could be available in the black market, etc., etc. So there needs to be a regulatory mechanism which takes care of these activities which restrict the availability of to the genuine care receiver, somebody who needs it genuinely, the care center which requires it genuinely, as compared to being hoarded in the black market, for example. Similarly, perhaps the third next important aspect is what happens to these children who have lost particularly both their parents. And it all started right from the migrant streams who were traveling back home. There are children who found their mothers lying dead on the railway platforms. There are children who found their parents having killed in the road accident. There are friends who have been carrying one of them carrying the other one who was infected, and who, the moment they were discovered as one infected, they were thrown out of the vehicle from those among the same set of migrants with whom they've traveled midway. So the point I'm making is that there needs to be a system to collate information on these kind of individuals, put up mechanism in place in terms of ensuring that certain support for these individuals can be built in. For example, orphan children, can their schooling, can their education be the responsibility of state? Can the young people who have lost their work be given employment of certain kinds which is conducive to their educational qualification? And most importantly, since the second wave has claimed a lot of young people, what happens to the elderly parents if they have survived their young children? Do we see them? Do we see certain kind of support system which can be built in terms of collating information on these individuals, evolving certain kind of systems which will make sure that they are registered, they are recorded, and systems are put in place to be able to do the needful towards these individuals. So I'm going to stop here. Thank you very much, Professor Moni. Over to you.
Thank you, madam. I'm able to see the human face of the health informatics today after listening to your address. And I have been propagating health informatics for more than 15 to 20 years. But today I am very happy. Now, I was listening to you as a student when a teacher is delivering the talk. And these are all some of the important components which you spelled it out. And for the benefits of the participants, I would like to summarize appropriately so that nothing is lost in its understanding. And, one is that you have completely done the strength and weakness and opportunities and the challenges of the healthcare delivery systems, and also very nicely, defined the health informatics, system, the components, and also the need for value creation network and the value chain network. And this, you also said it, that how the problems associated or the do's and don'ts of these health, these informatics value, network value chain. And you also pointed out very effective. And that's the reason only, in this webinar series, I have concentrating on health informatics network value chain. I'm bringing different aspects and from different experts of different understanding. And I'm very happy that this will strengthen the health informatics network value chain. And remember that 85% of the disease which we get come from animal. You very nicely said it is not a new word. It's even the one health in one medicine, everything is there for the last more than 100 years. But whether we have taken into consideration is a different question. And we question everything in this country. And when you talk about our own Indian system of medicine, which is there being practiced for centuries together, but we question it. What is the scientific, evaluations and so on and so forth. And the time has come that between the first wave and second wave, now they talk about third wave as if these waves are all as if it has been well defined, even though we do not know. But the way in which now you have put out the chronological order in which you depicted the data, as a technocrat, I feel that these are all dictated terms which is coming out. 3 days, within China telling that is a human-to-human interface. Within 20 days, 170 people have been identified, more than 175 have been identified out of China. And this is some of the things that how the Chinese were able to get the disease out, virus out from their land. This is the question one has to look into it. Who are all party to that? Is not only involved in it, party to that. And today you have seen that it has gone to every nook and corner. Even it has even our own country. It has even reached Andaman Nicobar Island and Lakshadweep and Minika Islands, which normally people don't even go. I have visited, and it is a distant, is completely distant part for the mainland people to visit. But today in your talk, I am very happy to host today's your talk in this important webinar series, that it is the fifth in the health informatics value chain network talk, and you brought it out very nicely. Apart from your own more than 3 decades of research in this area, in the social medicine and community medicine and community health and public health, you defined it very effectively. And I am very happy that the health informatics network value chain, which I have been voicing as an informatics scientist and a technocrat working in government, it is essential. In 2011, I was asked to present a talk in National Agriculture Science Congress at Lucknow in 2011, where I was asked to talk on how to reduce the farm loss. So I took integrated farm health management systems. And then in 2012, because of the that we have to have the national animal disease reporting system, and that time the World Health Organization for Animal Health, World Organization for Animal Health, based at Paris, that is OIE, they have listed out 143 diseases. The country took vast advantage to network a national animal disease reporting system connecting 7,032 locations. I was instrumental in operationalizing that 7,032 locations in the country. Operationalized and dedicated to the nation in 2012. And that gave a very big, if that network system would have been operationalized effectively from 2012 onwards, 2013, after my retirement, that network has not been in operate. I voiced it in many forums. 7,032 locations. What was expected was the next telemedicine component of connecting block level veterinary officer to the livestock farmer. That was I gave in 12th 5-year plan. I have given a lot of components how it has to be networked and so on so forth. So if this would have been done in the 12th 5-year plan, we would have got almost all databases at the village level to take note of it. And that is the one thing which I was feeling completely disappointed. And then 1985, I was involved in as the project director for district information system of NIC, where I have envisioned 28 sectoral database development programs. Till it is very relevant. In this country, we don't even have a comprehensive village level information system. Comprehensive village level information systems. And that time we didn't have technology. We had a very limited level of technology, not a sophisticated one, but we have proposed a strong information system. And even now, with this much vast of technology, we were nowhere near what was proposed in 85. I'm still alive. And then 95, I was instrumental on visualizing an informatics blueprint for sustainable agriculture development. An animal production and health informatics network was voiced in 2000. And I proposed in Veterinary Council of India. I was asked to advise, address that to Veterinary Council of India, talk to IT in animal production and health. And these are all some of the things that which we have taken. We have done it effectively. But these situations during the last 2 years has given an opportunity for us to revisit completely. That's why I'm also as a principal advisor to e-health systems technologies. Now we are I told the company that if I want to become a principal advisor, you please network all the systems components. And this country, we need to have health informatics professionals very effectively. We have a data from the lab which is digitized. We have a doctor, he doesn't have a time to look into the data. And we have so many hospitals, the data which gets generated from the laboratory, there is no trained professionals on informatics to understand. So this is an opportunity where I've seen it, that why can't we have an MSc and BSc health informatics program to train the people with the basic biology background as a paramedical professionals to take advantage of the data and the informatics technology. And that's where I was trying to bring out all policy papers and so on and so forth. But with the COVID situation, that's why I in my address, I talked about that how Taiwan has come out very effective. And today, we talk about so many things that today with the Aadhaar, we should be able to build the health informatics value chain very effectively. We should make it a health passport. And so that every person is identified. There is no point in hiding our disease. This is that if we are able to take care of and you are able to have this data profile available, we should be in a position to save individual very effectively, well in advance. And that is where that, I'm very happy in your address. You very effectively you talked about the problems, you talked about the challenges, you talked about the opportunities, and then you entered that this is where that network value chain has to be impacted. It has to be talked. It has to be improved. And the do's and don'ts, what are the problems we witnessed it? And it is a very effective address. That's what I invited you to deliver a talk with the accent that this is going to galvanize and motivate the people who are going to listening to the lecture. And I have received a mail from the engineer, a telecom engineer, retired as a voluntary, she took a voluntary retirement, retired as a, assistant general manager of BSNL. She has sent a message that this is a very effective address. This is from Kanyakumari district. It has come down, and it means that people are watching that. They say that how important the social medicine is. It is. That's why the doctors have to see beyond their medical chart, which they are being, shown to them. And you very nicely said it, that the different components of public health informatics. And I am very happy that today that I was able to listen to you for more than 1 hour on the impacts and the need for health informatics with very variable components. And it's very important. And I hope that the topics, the areas of research which you talked about it, will have an impact among the research scholars. But I would like to promote this as a health tech startups with the social medicine as the core, patient at the common public, not as a patient, public as a core, and the doctor as one of the components. Now today doctor is the core, and now public as a core, and bring in all the related stakeholders together and build up the health informatics network value chain. As Dr. Jawaharlal Vinancha very nicely said it, we have to seize the opportunities, in open innovation and value creation network in the digitalized world towards a self-reliant India, self-reliant economy. This is what, Madam, you have emphasized today in your talk, and we thank you very much for taking your time to participate in our international webinar series on open source digital technologies for self-reliant India. And this, we will convert this as a policy paper, and we will forward to you for corrections, and with your authorship, this will go to the concerned policymakers in the central government, and we'll also make it available to the state government. And we are also going to have a school of health informatics and computing and in the university, and we'll be very happy to have your association with the the school of Center for Health Informatics and Computing for the time to come. With this, I thank you very much, and we thank all the participants of this international webinar series for your participation, and we greet from the Sobit University. For more research inquiries, please contact Professor Moni Madaswamy, Professor Emeritus and Chairman, and former Director General, National Informatics Center, Government of India. My email ID is moni@sobituniversity.ac.in. Thank you very much. Have a nice day. We close the webinar and leaves to you.